Welcome to the On Target podcast. On this podcast, we discuss the ins and outs of radiation therapy. We talk with doctors and patients about what to expect during radiation treatment. Each episode will be a unique perspective of different aspects of radiation oncology and radiation treatment. For more information or to learn more about radiation treatment, please visit our website, rtanswers.org.
Welcome, everyone, to the On Target podcast. My name is Niema Razavian, and I'm a resident physician at Wake Forest University School of Medicine. In today's episode, we will be discussing a general overview of external radiation. To do this, we have Dr. Sameer Keole, who's a attending physician and professor at the Mayo Clinic, Arizona, and incoming chair of the American Society for Radiation Oncology. Welcome, Dr. Keole.
Thank you for having me.
Let's start from the beginning. Can you tell us more about external beam radiation and what that means?
Sure. External beam radiation, and sometimes it's called teletherapy, but most people will call it external beam radiation therapy. It's radiation from the outside in. We'll typically use high energy X-rays. Sometimes we use something called electrons, but typically high energy X-rays, which are also called photons. So the listener should not be confused if they hear those true terms. They're the same. And they come from the outside in. They're generated within a machine called a linear accelerator. This differs from internal forms of radiation, most commonly called brachytherapy, where the radiation is from the inside out. In that situation, the radioactive material is sometimes implanted in the form of radioactive pellets, or sometimes actually given through an IV, or sometimes even given via a liquid form that you ingest.
And is radiation given from outside the body, can it be used to cure cancer?
It can, and it's highly curative. We broadly use radiation therapy in three settings: curative intent, which is the majority of what we do, and that's either before surgery or after surgery, or sometimes by itself. We can cure cancers just with radiation alone. Sometimes we give it in a palliative manner to help make pain go away or other symptoms go away. And sometimes we give it prophylactically. Sometimes we give it before an orthopedic procedure to prevent bone spurs from happening, say in the hips. So it depends. Those are the three broad categories, but curative and palliative are the two most common.
And you talked about the different categories. What about the timing of radiation?
Great question. So sometimes we give radiation either before a procedure or after a procedure by itself. And the radiation itself can last anywhere from as little as 1 day and sometimes 8 weeks, sometimes more, but that's pretty rare. But somewhere in that ballpark, and that's a good discussion between the patient and the radiation oncologist.
And to review, who prescribes radiation? Are these people radiologists?
Good question. They used to be radiologists about 60, 70 years ago. So it's something that people remember, but no, for the last 50 years, a radiation oncologist prescribes radiation, although radiologists are kind of like our cousins. We are all board certified by the same group, the American Board of Radiology, but a radiation oncologist is a physician. So a physician has either an MD or a DO behind their name, and after 4 years of medical school, and sometimes more if they have a PhD as well, they undergo a minimum of 5 years of training with 10,000 hours that is heavily oncology focused.
Now, radiation has a lot of specific terms that get thrown around, and our patients love to go on the internet and come to us with these terms. So let's review some of the word soup that goes on in radiation oncology. So what is EBRT? What does that stand for?
EBRT, external beam radiation therapy, and that's the radiation that comes from the outside in. The most common machine used for this is called a linear accelerator. You might hear the slang LINAC, but that's a linear accelerator. And again, that's going to generate radiation that comes from outside the body and goes inwards.
What's a gray?
A gray is a unit or dose. It's our currency. So I try to explain this to patients. It's the milligrams used in drugs. We use gray. The fancy term is a joule per kilogram, but sometimes I use the term of dollars and cents because that's something patients understand. So sometimes patients will come in and they'll get $2 on a given day, and they'll put it in their radiation piggy bank, and they'll come back the next day and get another $2, and they might come back 35 times for a total of 70 gray or $70 of radiation. Sometimes they'll get $15 of radiation in one setting, 15 gray in one setting. So it really depends on the clinical situation. But it's the currency we use to describe the amount of dose we're going to give to a patient.
I like that radiation piggy bank
Yeah,
analogy.
thank you.
And so you were talking about sessions. So how do radiation oncologists describe each of these sessions?
Probably the non-radiation oncology listener would really identify more with a session of radiation, and that's perfectly fine. The term that we use in the chart or the electronic medical record these days is a fraction. So one fraction is one day or one session of radiation. It's probably more accurate to say one fraction equals one session, because occasionally we'll do something called BID or twice a day radiation, where the patients will get 2 sessions of radiation in a single day. We don't use that often, and when we do, there's a 6-hour split. So the patient will come in the morning and then again in the afternoon.
I think it's important also to emphasize, as you mentioned before, that the number of sessions or number of fractions will vary by disease site.
Yes, good point. Depending on the different disease, we'll use a different number of sessions or fractions. And in fact, even for a single disease, a patient may be appropriate for a different number of sessions or fractions. For example, prostate, we sometimes do as little as 5 sessions or fractions, and sometimes we use as many as 45. And so it really depends on that particular patient's unique cancer and what's best for them in their clinical situation.
And in the field of radiation, there are always new technologies coming on board. One of these relatively newer technologies is something called SBRT. What is that and when is it used?
So stereotactic body radiotherapy is also called stereotactic ablative radiotherapy, SABR. Stereotactic means we know where the tumor is relative to the patient in 3-dimensional space. We take that for granted today. And quite frankly, everything we do today is stereotactic. This was not really the case 20, 25 years ago when image guidance was not as prevalent or standard. So that's really where that term came from. It's historical, but it stayed in that acronym. So it really means we're localizing in 3D space, and it at the time meant we were going to give a higher dose of radiation in a fewer number of days. And the fewer number of days is typically defined as 5 days or less of radiation. It started with lung cancers and prostate cancers, but we now use it actually in a wider variety of cancers.
And it's one of those things that it will vary again based on the patient and their specific cancer, whether or not this type of treatment is offered.
Absolutely. So we use stereotactic body radiotherapy or stereotactic ablative radiotherapy. Again, those terms are interchangeable. We use them across really for a wide variety of conditions, anywhere from the head almost down to the toes, depending on the patient and their individual characteristics.
And speaking of another stereotactic technology, there's also something called SRS. What is that?
SRS stands for stereotactic radiosurgery, which has a fascinating history. It's been used since the 1950s. And again, it was really our first foray into true stereotaxis, meaning we can really localize in 3-dimensional space. And this has to do with giving high doses of radiation into targets in the brain, and typically given in just 1 day of radiation. This can now be done on a variety of different platforms and machines very, very well. Some of the commercially available machines that you may hear are Gamma Knife or CyberKnife, and these can also be delivered very well on a linear accelerator. So this is a very common type of radiation being used today. Again, stereotactic radiosurgery or SRS.
Now let's review the logistics of external beam radiation. What is the first step in the process?
The first thing we do is we see the patient. And so that's called a consultation visit. And we'll do a lot of things at that consultation visit. We want to review the history, the imaging that's been done. the biopsies that have been done, and the surgical pathology. It's pretty rare we'll see a patient without having the actual pathology before we see a patient in consultation, but we do occasionally. Generally speaking, we want to make sure we have a known diagnosis of cancer before we see a patient. After that, we'll do a thorough physical exam, but we'll really focus on the area at risk. So, for example, for head and neck, we'll inspect the skin. We'll probably look inside the ears and in the nostrils, look at the eyes. And sometimes we'll do a laryngoscope where we'll actually place a fiber optic camera down the patient's throat and take a look at the inside and see if there's a cancer and exactly how it looks. And then finally, after getting all this information together, we'll discuss with the patient if the patient needs radiation. If so, what type of radiation would benefit the patient and how long the patient should get radiation for. And sometimes we have to give the radiation in conjunction with chemotherapy. And so these are all things that we discuss with the patient. And we have a discussion with the patient of this is the benefits and this is the risk. And so why are we doing this? What do we expect in terms of cure rates? And also, what are the potential side effects of radiation? And are the side effects higher if we give additional agents? It's a very thorough discussion. It's not unusual that a consultation can take well over an hour.
And if a patient decides to proceed with radiation, what's the next visit?
So the next visit, sometimes we discuss it there, and sometimes the patient wants to think about it. We do have to obtain informed consent, and that's very important to us. This is a two-way dialogue with the patient. We want to make sure the patient understands what we're doing, why we're doing it, and then the patient, if they decide to proceed with radiation therapy, they're going to come back for a simulation visit. Typically, the first thing we do with a patient when they come back for the simulation visit, it sounds basic, but we're going to ask you, what's your name? Why are you here? What are we treating? Where are we treating you? Even though these sound like basic questions, we want to make sure that we're obtaining the right information and the patient knows they're there. Once we're comfortable with that and we make sure that informed consent has been obtained, then we start the process of the CT simulation. We put the patient in the same position they're going to be used for treatment. We typically will acquire images on a CAT scanner, and sometimes we obtain additional imaging, an MRI or a PET scan, and we do what's called a fusion. We essentially glue it to the CAT scan so we can get additional information. This goes over to a CAD system, a computer-assisted design program, but essentially we call it TPS, treatment planning system. And once it's there, the radiation oncologist works with a member of the team, most commonly a dosimetrist, to basically draw the bad stuff, the stuff that we want to treat, these are called target volumes, and the good stuff, the stuff that we want to avoid. And we come up with a plan to avoid it. In the room called the simulation room where we acquire the CAT scan, we want to make sure the position is reproducible. It's very important that the simulation carries over to day 1, which carries over to day 5. And if there's 40 days, that carries over to day 40. I use the analogy of sometimes you're going into a subdivision and they're all a series of tract homes. We want to make a blueprint and essentially build the same exact house maybe 30 straight times. So that's why creating the right immobilization at the CT simulation is so important to us.
And another question I'll often get asked by patients is, by the time they see us, they've already had a CAT scan or had an MRI. I mean, do they really need to do this CAT scan in the simulation visit?
Yeah, that's a great question. And so what I tell patients is I understand you've already had a lot of imaging and you're probably tired of getting imaging. The thing that makes our imaging unique and different from the imaging they've had in a radiology department is that our simulation room is linked to our treatment rooms. So we know where that patient is in what we call three-dimensional space relative in our simulation room to the treatment rooms. And so we have a coordinate system and we can create a plan, and making sure it's done in our department ensures that we can deliver that plan on a daily basis and send the radiation exactly where we want to send it.
Now, after the simulation is performed, how long does it take to get the radiation plan ready and to get started with radiation?
It depends. And so the time from simulation to first patient treatment, and it's a question that's commonly asked, it depends. Sometimes the radiation is fairly straightforward and we can start within a day or two. Sometimes we start the same day. We do have radiation emergencies where patients are in very bad pain, and we might see them at noon and start radiation by 2 or 3 p.m. But more commonly, it's going to take a few days, and sometimes it could take as many as 2 weeks to start the radiation. So it depends on the particular patient and his or her specific needs.
And the goal, let's say if it's taking 2 weeks, would be to make sure that this is a safe and accurate plan.
That's correct. It's a safe and accurate plan, and sometimes plans can be very complicated. For example, head and neck cancer, there sometimes could be 50 different structures and organs that are contoured between the radiation oncologist and dosimetrist. It's incredibly meticulous, and this just takes a lot of time. Others are maybe not quite as complicated to plan out. So, again, it really depends on the patient and their particular needs.
I always like to mention to patients that that time is really spent to make sure that this is a safe and effective plan. And there are several behind the scenes people that they might not see that really make sure that this is the best plan for them.
Yes, and that's a great point. Again, radiation oncology is a team sport. And so the most important thing we do is make sure that radiation gets into the patient as safely as possible. And so to do this, we have multiple steps in the quality assurance process. And there are many, many people that are a part of this effort, from the physician and the dosimetrist, but also physicists and physicist assistants. Not only do we do quality assurance on that individual plan, but we're also doing constant quality assurance on the machines that deliver the radiation, and also the image guidance, as we call it, inside the room that ensures the radiation is going to go exactly where it's supposed to go. Quality is arguably the most important thing we do, along with safety, and we make sure that the radiation is delivered exactly the way we want it to be delivered.
You emphasize the safety and the accuracy of the radiation plan. So once that plan is ready, generally something happens that's called a verification simulation. Can you tell us about that?
So we'll oftentimes do a verification simulation or a VSIM, and we'll do this before we deliver any radiation, and we'll make sure that the patient is in the exact same position prior to a treatment as they were when they were simulated, maybe anywhere from a day to a week earlier, because that's our final check to make sure the radiation is going to go exactly where the radiation oncologist is prescribing for it to go.
Once treatment starts, what are the logistics? How often is treatment?
Typically, but not always, it's one treatment or one session per day, 5 days a week, Monday through Friday. Occasionally, we'll give radiation every other day or sometimes once a week, but the majority of, and when I say majority of the time, I would say 90% or more, we're giving one session per day, Monday through Friday.
And how long do these daily treatments last?
We tell patients to budget an hour from the moment they enter the facility to the moment they leave. Now, the reality is the radiation itself is only on for 1 or 2 minutes. In fact, the patient may only be in the room from anywhere from 20 to 40 minutes, depending on the case. So it's really important for the listener to understand that while the radiation is not on for that long, there's a lot of what we call intra-service time that's critical to make sure the radiation therapy is delivered right. For example, the patient's going to come in to the door. They're going to be identified at the front desk. They're going to be asked identifiers to make sure we have the right patient. They're going to go to the gowning area. Sometimes they'll have to change into a gown. The therapist will come and escort them to the room. The therapist will again ask, "What is your name?" Even though they may have seen them 20 times. And they will do typically 1 to 2 different identity checks, take them into the room, and then from there, they're placed in the exact same simulation device that was created at the time of CT simulation. They'll make sure that the external positions are correct. Oftentimes, we do image guidance prior to the radiation being delivered. So this can take quite a bit of time to make sure the patient's set up just right. And then, and only then, once we're assured the patient's in the correct treatment, is the treatment actually administered to the the patient. Once that's done, therapists will go back into the room, help the patient sit upright, and they'll get off the table, go back into the gowning area, and be free to go that day. And again, the whole process, it's not uncommon, from door to door will take about an hour.
So I think it's important to emphasize your earlier point about making sure that this radiation is safe and accurate, and that time spent in the room is how we do that on a day-to-day basis.
That's correct. Yes. I think a lot of patients and a lot of people think you just go in and the radiation's on for just a few minutes and that's it. But it's actually a minority of the time in the room. The majority of the time in the room is spent making sure the patient is set up correctly. So we're going to deliver the radiation exactly the way the radiation oncologist intended for it to be delivered.
And you mentioned a radiation therapist. Who are they and what role do they play in the delivery of radiation treatments?
Yes, radiation therapists are highly trained individuals who have undergone several years of schooling themselves. They work the machines. They're very good at imaging themselves. They are our front line. They are entrusted to deliver the radiation from the machine into the patient. And so they have several aspects to their job, but they're the ones who are the most hands-on with the patient on a day-to-day basis. They're a critical part of the treatment team.
And after a patient receives external radiation, are they radioactive?
No, the patient is not radioactive at any point during this process. And when they leave the department, they can be assured they are not radioactive. They are not at a risk to themselves or anybody around them.
And for patients getting external radiation, how often are they seeing their radiation oncologist during treatment?
They will see their radiation oncologist at least once a week. That's the minimum. Sometimes patients may need to see their radiation oncologist more often, depending on the clinical situation, but typically a minimum of once a week. But we're ready to see the patients whenever they need to be treated.
What are the goals of these weekly visits?
Good question. So the goals of a weekly visit are severalfold. First, we want to see how the patient is tolerating the radiation. Depending on where the patient is being treated, there are certain expectations on how the patient should be doing depending on their time course. And so we want to make sure it's appropriate. Sometimes they're having symptoms, and many times we can help manage these symptoms with fairly simple interventions. It might be as simple as prescribing a medication. Sometimes we have to give patients IV fluids. And so it really depends, but it's critical to make sure that the patients are progressing the way we think they should be progressing. And if they are having side effects, that we're doing everything we can to manage those so they don't miss treatment days.
And if a patient's having an issue outside of their weekly check-in day, who should they let know?
If a patient is having issues outside their treatment day, we encourage them, don't wait. Don't try to tough it out till their next scheduled treatment day. Let the nurse, let the doctor know, and they can do that a variety of ways. A lot of times patients will message us through the inbox portal. Sometimes they will let the front desk know, and then we'll get a message or a page. There's a lot of members on the team that really care about the patient, that want to make sure that they're getting the treatments as prescribed without missing days. So let someone on the treatment team know, but ideally the nurse or the doctor, and then we can see them and we'll figure out what needs to be done.
And again, going back to your point of safety, right? These weekly visits are to help ensure safety of the treatment itself.
Exactly. Another key part of the weekly visit happens behind the scenes. We're reviewing the images anywhere from once a week to daily. Sometimes we get reports on, we'll place external, basically radiation monitors to make sure the right dose is going to where it needs to go. So we're basically making sure that the radiation is being delivered exactly as we prescribe it in a variety of ways.
And once all the treatments are completed, how will patients know that they're, let's say, if we're going for cure with radiation, how will they know if they're cured?
That's a great question. And that's probably the most common question we get. Doc, how do I know we got it all? How do we know the treatment worked? And I tell patients it's a simple and fair question. It's often a very complicated answer. We'll usually see a patient anywhere from 1 month to 3 months after completing the radiation therapy. Depending on the disease site, if it's a brain tumor, we'll often get imaging every 3 to 6 months for several years. Or if it's a patient with prostate cancer, we'll get lab tests, most commonly a PSA, starting at 3 to 6 months after. And on some regular interval for several years. And so it really takes usually a couple years to sometimes several years to know if the cancer treatment worked.
So it sounds like once treatment's over, there will be follow-up of
Yeah.
some type.
Yeah, it can be a lifelong relationship. At minimum, it's a relationship that can go on for several years. And so the radiation oncologist is definitely an important part of what we would call the longitudinal care team. It's not just the time we spend with the patient during treatment. Follow-up can go on for years, which is actually very rewarding for us.
And if a patient finishes radiation and, we're a couple months or years after, and they're concerned about their cancer returning or a new symptom, is it fair for them to go back to their radiation oncologists and let them know?
We encourage this. And so sometimes we will discharge the patients from routine follow-up after a few years, but we make it clear to them that, hey, we're always here and we're your doctors. And so if you do suspect unexpected late side effects or something that doesn't make, they know their body's the best, or something that doesn't make sense, to reach out to us so we can either counsel them by phone, and if need be, we can schedule them to come back and see us in the clinic.
Well, thank you, Dr. Keole, for joining us today on this episode. You provided a very thorough explanation of how external radiation works. For those of you listening, we will have future episodes on different types of radiation and how those work. But if you have more questions about external radiation, please go to rtanswers.org.
Thank you for listening to this episode of the On Target podcast. This episode has been brought to you by the American Society of Radiation Oncology and our care partners. For more information about topics discussed in this episode, please visit our website at rtanswers.org.